Good afternoon, everyone. Welcome to the second series of the Improvement Showcase hosted by the Commission on Excellence and Innovation in Health. And this one is a cracker. It is Data in Action. Just a reminder that we are kicking off recording, and so this first part of the series, the showcase today, is recorded. So just to let you know that, and I'll talk through housekeeping in a minute. The Commission on Excellence and Innovation in Health has a vision of together, let's create better healthcare for South Australians. And a strong component of how we achieve that is by bringing people together to share their stories, collaborate and innovate and work towards that vision of better healthcare. Firstly, though, we would like to acknowledge this land that we meet on today. It's the traditional lands for the Kaurna people, and that we respect their spiritual relationship with their country. We also acknowledge the Kaurna people as the custodians of the Adelaide region, and that their cultural and heritage beliefs are still as important to the living Kaurna people today. So the CEIH Improvement Showcase is every Thursday at 1 o'clock, and you can subscribe to the CEIH via the Eventbrite. That's where we post all of our upcoming events, and we also let you know on LinkedIn and in other forums. If you can't make it to the Thursday session at 1 o'clock, then please check our website or our YouTube channel, and you can always catch up on the latest that's happening in the Improvement Showcase series, because we do record the sessions and we do post them online there so that you can catch up when it's convenient for you. Have you got a story to tell? We would love to hear from you. We are in the process of establishing what the series will look like for the next few months. We're really interested in stories where you've had a wicked problem that you've succeeded in solving, that you've learned something, and that you have particular themes that you'd like us to explore through the improvement series. We really want to know where you've identified the need for improvement through data, clinical outcomes or operational performance, how you designed that, whether it was with the community and the co-designing process with clinicians, what kind of method you used, whether you did through the PDSA type cycles, and what you learned through an evaluation process, considering things like patient outcomes, clinical outcomes, cost and volume. What were the insights you gained? And that's really what this second series is about. So we encourage you to get in contact with us. Our email address is there on the slide, ceih@sa.gov.au. And so just a bit of housekeeping. As I said before, this presentation is recorded. What we do is for about the first 20 minutes, we have the presenter share their story with us. And then at the end of their presentation, we stop recording and open the session up for questions and answers. And we ask that whilst the presenter is speaking, that you put your microphones on mute and your cameras off. However, when we get to the question and answer session and we stop recording, then we would love for you to turn your cameras on, turn your mics on, or you just utilize the chat function to really engage, because as I said, this is really what we're about, is sharing stories, collaborating, learning from each other, and also seeing where there's opportunities for us to partner and network. So as I said, this is series 2, Data in Action. This series is running through May. Last week, we had Dr. Andre Andrade talking about precision public health going digital, and he shared his fantastic story working with Veterans Affairs data and how they have been converting a lot of their work at scale into digital infrastructure, and how they've been working with primary care settings to really drive change. Next week, on the 27th of May, we have Associate Professor Rosanna Tavella. She's a clinical data manager in cardiology at the Queen Elizabeth Hospital. She's going to share her story on coronary angiogram database of South Australia, CARDOSA, a nexus between clinical research and health service delivery. We really hope you join us for that one, and come ready with lots of questions for Rosanna. But this week, we have Rosie Tiramaku. She is the Manager of Operations and Research for the ICCNet program in South Australia, and her presentation today is improving cardiac outcomes in country South Australia. Rosie has been on a 20-year journey of developing and implementing and evaluating the ICCNet service, and it is a world-class, world-recognised solution. And we're really excited today to have Rosie share her story. So I'm just going to move now to stop sharing my screen and invite Rosie to share hers and begin her presentation. Just a quick reminder, please, microphone's on mute, and we'll let you know when we stop recording this session and open up for questions and answers. So Rosie, over to you.
Okay, thanks Tina for the kind words, and I'm really appreciate the opportunity to talk about this work, which has been really Phil Titterman's and my journey over 20 years, and also the ICCNet staff. So I'm really pleased to present on behalf of the whole team. Okay, so to put it in perspective, I just really want to show this slide, which shows that South Australia covers 1 million square kilometres, and we have a population of 1.6 million. When you think about organising resources, for the communities, you have to realise that it's really hard in some of the smaller communities to have a full-blown health service. When you think about South Australia with its 1.6 million, the closest is South Africa that have 51 million people. So that lies the problem in South Australia. We have huge geographical challenges to deal with. The work that inspired us 20 years ago was a paper from Sexton & Sexton, which really showed that there's more AMI deaths in country areas when compared to metro areas. And this kind of really inspired us to start thinking about what could we do to sort of solve this issue. So just a bit of history, we're a rural cardiac clinical network. We started in 2001 as ICARNet, and what prompted us was really to double the rate of ACS mortality compared to metro areas. In 2002, we were successful in getting an AMAC grant. April 2006, ICARNet became known as ICCNet South Australia, and we were funded by the then Country Health SA to become a statewide provider cardiac network. This funding came through SALN. In 2010, I like to think because we started to show some good outcomes, we were incorporated into Country Health and we reported directly to the Chief Medical Officer. I think ICCNet is a really good example of research translation into clinical practice. So our aim was really to understand the causes and eliminate disparities in CVD outcomes between metro and non-metro populations. What do we do to start off with? Well, we went to the grassroots and we spoke with all the rural clinicians to identify what were the things that were maybe preventing them from practicing evidence-based cardiac care. The things that they came up with were advice in ECG interpretation, because a lot of these doctors wouldn't see AMIs very often, or some of the more obscure cardiac conditions. So they really wanted some help with ECG interpretation. Access to biochemical markers within the recommended timeframe, which is 60 minutes. And if you can't do it within 60 minutes, they recommend point of care. And access to advice from a consultant cardiologist. There was other things, but these were the three main things that the rural GPs thought that they needed help with. So really our objectives were to support the primary care doctor in the diagnosis of evidence-based management of cardiac presentations, analyse the needs of the primary care teams with respect to design and implement a sustainable, appropriate CME, clinical resources and clinical systems. And really we had to accommodate different levels of experience within the clinician group. So our methods were, as I said, grassroots needs analysis with GPs and nurses, evidence-based clinical pathway for the presentation of chest pain ACS, point of care pathology. You've got to remember only 10 of our 65 hospitals actually have a laboratory. So for those of them without a laboratory, a troponin result could be anything from 3 to 4 hours to 48 hours if it was over a weekend. So it was never really being able to be used to assist with the diagnosis of the patient or manage the patient. A 24/7 consultant cardiology telephone backup for ECG interpretation, and to assist the rural doctors with clinical decision making. this paging service has become, incredibly important, I think, to the rural doctor workforce, and something that's really highly valued. And certainly when other like cancer networks or pediatrics, whatever, want to organise a support service, they always say, just do what ICCnet do, because it works, and we've been doing it for 20 years now. Routine availability of third generation thrombolytics for SEMI patients. When we first started, they were using an old thrombolytic that the Metro had stopped using ages ago. The cost was prohibitive, so we worked with the hospital bean counters and management to actually make sure that everyone had the appropriate drugs, and really remove the barrier to rapid transfer of high-risk patients to tertiary care for the early access to coronary angiography, which is really needed and part of the evidence base. And of course, to provide regular CME to rural practitioners. So this is our resource that we put in every emergency department, which is really a management pathway for chest pain. So it tells the local clinicians exactly what to do, what the initial treatment is, diagnostic testing and risk stratification process. And that's incredibly important that people follow this, because if they don't and they run into problems, the coroner certainly would ask them why they weren't using the tool that's been approved by all the metro cardiologists in town. So that's an incredible, important resource. Access to digital ECG. So we were fortunate enough in 2006 to be able to get money to purchase a digital ECG system across all the ED departments in country. And that was important because sharing of a digital ECG is way better than a fax, which is really difficult for people to interpret. Interestingly enough, I just posed the fact that we have an electronic database for ECG, but currently the metro hospitals are scanning ECGs into Sunrise, and I kind of find in this day and age that to be amazing, really, and had a recent complaint from one of the regional directors of nursing as to why that is the case and the waste of resources scanning ECGs. We mentioned before the access to the tenectoplase, which is really important. We actually rotate the stock to make sure there's as little wastage as possible in the hospitals. It's almost about $1,900 a pop for the tenectoplase. So clearly you don't want to waste too much of that. We have a really good system in place now, and I think over the last 12 months we've only lost one vial, where in previous years we were losing maybe 50 vials or whatever. But we've perfected our processes, have a really good courier on site that helps us to rotate that stock. Point of care pathology, as I said, with no labs, these rural doctors were working blind, really, just on looking at the patient. Now, why pathology is not the be-all and end-all of diagnosing a patient, it certainly assists the doctor in diagnosing and managing. So we started off with just troponin, but it was soon apparent that a whole heap of other tests were needed by these hospitals to be able to manage their patients in-house without having to send them off into town. The cardiology paging service is 24/7 service. We aim for a less than 10-minute response, and we actually, even though this is early data, we still probably about 8 minutes average response time to getting access to a cardiologist. So a lot of people say you can get access to a cardiologist faster in country than what you can in metro. The clinical resources for transfer of these patients. So we have common clinical pathways, we have a shared formulary and medication protocol, and we really integrate care between the hospitals, the rural doctors, nurses, allied health, tertiary specialists, ambulance service, and RFDS and MedStar. It's important that everyone works together. What we did was not really rocket science, it's just really integrating the care of the patient in country. So how do we go? This was the first bit of data that I pulled out, and I can remember when I did this graph, I was truly gobsmacked and had to contact Phil, even though he was busy consultant, and share with him our findings. And so what we found is, if you look at the red line, it's the southeast moving average in hospital deaths for ACS. And you can see, when compared to the black line with Southern Metro, it was double in country back in 93, 94. ICARNet started in 2001, and you can start to see a drop and the two lines merged together. So this was for us a real eye-opening moment, and obviously we were really proud of what we'd done and thought this was a really good outcome. So where to next from here is we had to look at data across all of South Australia, and with the help of Derek True, we were able to publish this in the MJA with our kind of 9 years of our results. So basically, 9 years of AMI data evaluated. We had data linkage, 30-day all-cause mortality. So we did all of this. And what we found, so there was quite a lot of episodes, so it was really strong data, and there's a strong association between network support and transfer of patients to Metro Hospital, a lower mortality observed among the transferred patients. But the most important thing for us was the 22% reduction in AMI 30-day mortality. For us, that was really fantastic. We'd seen it on a local southeast scale, but to actually see it across all of South Australia was really, really exciting. So really, what did it show? Well, our network spanning, a million square kilometres, based on integrated systems, has improved the uptake of evidence-based care and improved patient outcomes. So we kind of really did achieve what we wanted to. So what else do we have in terms of data systems in ICCnet? We have since developed the integrated point of care clinical systems, where all our point of care pathology, ECG, a whole range of results are held. So we've got thousands and thousands of results in this database. We recently also started collecting CTG information. We developed an app, so rural hospitals who needed help with CTG were able to contact or share their CTG with another person to get some advice. We've also developed a maternity referral database, so high-risk maternity patients can share their clinical information in real time, along with video conferencing, and that stops these ladies from having to come into town. So this database is generating a huge amount of data, which I'm sure there's lots of people will be interested in. The other database we have is some work that's funded by the country PHN. It's called My Health Pocket, and in here we have a whole heap of home monitoring information and point of care pathology that sits in general practice. So we have about 28 GP practices that are part of this program. I just want to spend a couple minutes on home monitoring, because that's really the flavour of the month at the moment. So it's really the early detection and intervention, improving quality of care for chronic disease patients, enhances self-management. It's effective use of the health system, optimising capacity and value adding to existing services. It's not an emergency service. It really is just to support these people with chronic disease and really to stop them coming into the emergency departments all the time, or their local doctors. And it does free up resources in in the country areas where resources are really quite precious. So with the home monitoring, we have a program for COPD, heart failure, diabetes and hypertension. And really what we've tried to do is create a chronic disease model of care that's integrated, patient-centric and technology-enabled. That's just a shot of our database, which shows the results coming into a central database. The monitoring data, it graphs, it does all sorts of fancy things, and that could be a topic for another day. So what are our key findings in the preliminary work with home monitoring is there's a marked reduction in hospital length of stay during the home monitoring period, reduction to hospital length of stay 6 months post the home monitoring, marked reduction in blood pressure pre and post home monitoring. Participants reported greater confidence with utilising technology, and in a patient satisfaction survey we scored 4.6 out of 5 stars. And there was increase in patient contact through telephone, with an overall reduction in face-to-face contact post the home monitoring. Another database that is really important to ICCNet is the Country Access to Cardiac Health. So this is our telephone cardiac rehab, but also face-to-face cardiac rehab database. It's now become a state database for cardiac rehab, as Metro uses it as well. And it really enables us to it's funded by the Country PHN, the telephone cardiac rehab service, and it enables us really to report on what's happening with cardiac rehab. The purpose of CATCH was really to increase participation in cardiac rehab through a telehealth service, establish if telephone cardiac rehab increases completion rates, and compare the clinical outcomes of CATCH versus a snapshot of before CATCH. So that's what we kind of did to implement the service. What the outcomes, the most important thing was a decreased length of stay for patients undergoing cardiac rehab to those that didn't. The average length of stay for CATCH lower than the 2011 population when CATCH wasn't available, and the significant difference in the mean number of all-cause readmission for patients in CATCH compared to the 2011 population, which did not have a CATCH telephone service. So just to finish off, that's what we've done. We've created databases to help us evaluate our services. We get funding for a couple of our services, so it's really important to show that the funds are being used wisely and that we're generating good patient outcomes. So from my perspective, the importance of good data is enables service to be evaluated. We be able to show or highlight weaknesses or areas for improvement. So you have a continuous quality improvement. I always say to my staff that nothing is ever stable. We should always review our processes all the time to see how we can improve them and better serve the patient population. So really good outcome data helps to maintain and attract funding for programs. And this is something I try to emphasize a lot to people who say, oh, I can't collect data, or I'm too busy, or not enough time. And I always say to them, well, if you don't have time, you might find you don't have a program moving forward because you've got no evidence that your program works. So I think it's something new, but certainly people are starting to listen. But it's incredibly important that we do collect good data to show that our programs work. Thank you, everyone. That's my presentation.
Thank you, Rosie. Preaching to the converted, I think, well and truly there. The importance of good data, absolutely couldn't agree more. So thank you very much for your presentation today. We are extremely privileged for you to share us this journey. And as I always say, data doesn't just happen. It takes people dedicated like yourself and the much broader team, both your team and the broader health sector, to really bring to fruition all of this hard work. So thank you very much for sharing that story with us. And we now will stop recording.